Thank you so much for joining us. I think we have some people still joining in, but we can do a little bit of introductions and get started while people are joining in. For those of you who are new to this format, there is a chat box that you can use to point out any issues or if you have any concerns. There's also a Q&A button at the bottom of the screen, and you can touch that in order to ask questions. We are really happy to take questions, and we'll try to answer those at the end in particular, but as we go. What we are going to do today is we have a wonderful set of panelists for you from different member agencies, and we're going to share a little bit of our knowledge and experience using telemedicine and have a discussion about telemedicine and the special considerations and the opportunity for innovation that exists with COVID-19 and the current situation. I'm going to ask our panelists to introduce ourselves in just a moment. Let me introduce myself first. I am a neuropsychologist practicing in the state of Michigan. I also do consulting work. I am a prior director of a residential treatment program, or oversaw a residential treatment program, and I previously oversaw outpatient autism services now as well. Currently, I just do clinical services and consulting. And my past telemedicine experience is primarily through the VA. And I'm from Grand Rapids, Michigan. So I'll ask our panelists to introduce themselves now, please.
Hello, I am Sherri Klingensmith, and I work for Presley Ridge. My role at Presley Ridge right now is that I'm the director of our outpatient program in Western PA, and I also oversee our outpatient service line. So I've had many other roles at Presley Ridge. I've worked in residential and our education service lines as well. So looking forward to the panel today.
I'll go next. My name is Nate Luongo. I'm a licensed clinical social worker in the state of Maryland. I'm the clinical director at Potomac Programs, which is a outpatient, intensive outpatient, and partial hospitalization program for adolescents and young adults. And we're located in the Washington, D.C. area. My background has been primarily with adolescents and young adults, working with families. In addition to that, as well as working with young people that have co-occurring mental health and substance use struggles.
And I'm Christopher Bellonci. Most of the time I'm going to have my visual off just because I'm in a rural area with low bandwidth, so it's better to be heard than be seen. I'm a past president of the Association of Children's Residential Centers. I'm a child and adolescent psychiatrist. I'm the chief medical officer at an organization called Judge Baker Children's Center in Boston, Massachusetts. On the Harvard Medical School faculty. And our agency does telehealth. We pretty much seamlessly converted to telehealth on March 16th. We also have a therapeutic school and have been teaching our students through remote learning using Google Classrooms since that time as well. We have about 120 students starting from kindergarten up to the 10th grade. I was a medical director at Walker for 19 years. And so very familiar with all the challenges that all of you working in the residential space are still undergoing.
Okay, what I want to do first is just provide some some basic knowledge just to give us some common terminology. And of course, I just lost that. Let me pull that back up. So let me just start with what is telemedicine or what is telehealth? You'll see these terms overlapping. You'll also see other related terms like teletherapy, telepsychology, telepsychiatry. But basically, when we as practitioners deliver services over a telecommunication format, and that includes the telephone, that includes video teleconferencing software, whether that's in a standalone video teleconferencing device, or if it's using a computer like we are today, when we provide clinical services using those formats, that is telehealth or telemedicine. What determines at a basic level whether you can provide telehealth services? There are several factors to consider. One of them is, are you competent to do it? we should all be thinking about what we are experienced with, what we know how to do, and we should carefully consider whenever we make any change to our clinical practices, whether or not we have the right skill set to be practicing in that kind of way. For instance, if you are not very comfortable with technology, then before you think about telehealth, you may want to spend some time acclimating to the technology. Another aspect, obviously, of whether or not we can provide telehealth services is whether the people who we serve are willing to receive services in that kind of way. That is both a matter of their personal preference as well as other kinds of considerations like the technology that they have access to or other circumstances. After we consider all of those things, one more layer of telehealth services is, do we have the right technology in place, and do we have reimbursement setups where we can be paid for providing telehealth services? Here, you have to think about organizations that are stakeholders. So depending on what state you live in, your state has laws that, that govern whether services can be provided using telehealth formats. We're going to share some information, but I have a document from the American Psychological Association that provides a summary of each state and the basics of whether telehealth is covered in those states, as well as whether any emergency actions were taken with COVID-19. So you have to know whether or not it's reimbursable where you live, because this is not the same from state to state. And you have to know whether it's reimbursable for a funder that you're working with. Funders may have other special considerations, and even sometimes a funder may not be willing to reimburse for telehealth in the circumstance that you're in, even if they're doing it for other kinds of circumstances. And so there are lots of considerations like that to think about. If you've gone through all of that and you're able to provide telehealth, then you can think about doing that, and many of your organizations have done that. I'm sorry, let me just pull back up. I lost my list. Here we go. Okay. And then finally, so the last thing I want to talk about is something special that happened. As I mentioned, there have been a number of emergency actions, and one of them was a March decision that's called a HIPAA enforcement discretion. And I just wanted to make sure all of our providers are aware of this. What that means is that the federal government has not changed the HIPAA laws. HIPAA has a number of requirements surrounding doing telehealth. Those have to do with things like having a business associates agreement with a telehealth technology provider, like Zoom or Doximity, that provides telehealth services. That law is still in place, but during the current emergency, the federal government has decided to not enforce it. What that means is that providers can provide telehealth services over not necessarily fully HIPAA compliant, but secure telecommunication technologies. To give you an example of what that means, an example would be that Zoom, the platform that we're using right now, offers a HIPAA compliant option. If you pay for that option, then you execute a business associates agreement between your organization and Zoom, and you can have fully HIPAA compliant sessions on Zoom if you have the settings set appropriately, and they walk you through all of that. The HIPAA enforcement discretion means that during this emergency, you can use a regular consumer Zoom account without the HIPAA option and not worry about being prosecuted by the federal government, which doesn't exactly mean that it's compliant with the law, but the government is allowing you to do it during this emergency. Other examples would be using a service like Facebook Messenger, where Facebook Messenger communicates directly from you to the other person, or WhatsApp. An example of what you still can't do would be to have therapy via some kind of public forum. So like you can't do your therapy on Facebook Live where anybody can log in and see the therapy session happening. And you couldn't do it on something like TikTok either. But you could do it on other non-HIPAA compliant telecom systems like Facebook Messenger, WhatsApp, FaceTime or Zoom. And so I want to make sure people are aware of that as well. And we're going to pass along a webpage from the American Psychological Association that talks about that. Two, APA is recommending basically that providers seriously consider going ahead and executing a BAA so that they know that the services they're providing are fully compliant with HIPAA, even if there's a temporary allowance to not do that. And that's probably what I would tend to recommend as well outside of emergency situations. So that's a little bit of background information. And so what I've done is I put together some questions that I'd like to ask our panelists. As Amanda mentioned, please feel free to ask questions via the chat or Q&A, and we're happy to have that discussion. We're also providing you links, and we can provide you some documents either via our website at togethertovoice.org, or we can email those as well. So please allow us to continue the conversation that way. What I'd like to do next is open up the conversation to our panelists. The first question I have is, well, two questions. Does your organization routinely use telemedicine, and has anything changed since COVID-19?
Well, I could go first. Again, I work for Pressley Ridge, and we at Pressley Ridge have a number of different service lines, community-based, residential, educational service lines. And prior to COVID-19, we only provided telemedicine in the realm of psychiatry, and it was only at certain locations, depending on approval or not approval in that geographic area. So now, post COVID-19, we have switched to multiple service lines utilizing telehealth, as well as therapists included in, as well as all psychiatrists are utilizing it. So we've really been able to continue to provide. Our goal is to continue to provide the same service that we would face-to-face, but being able to do it through the telemedicine format. So it is definitely different, and it has been definitely been a change for us, and a quick change that we had to take on and move quickly, since we only had a very small portion of telemedicine being done at the agency prior to COVID-19.
Similar to Sherri, at Potomac programs, we have, again, a partial hospitalization and intensive outpatient program, so we're clinic-based. And prior to COVID-19, we didn't have any telemedicine per se. What we did have was phone coaching for our DBT programs. That was part of it. However, we always kind of viewed that as support that's in the moment for our clients, to help them guide them back to skills. So when it really seemed apparent that we needed to make a shift, we had to act very quickly. And so starting March 16th in our area, we went 100% virtual. So we had to find a way to bring our intensive outpatient and partial hospitalization programs completely online. And we've been virtual since then. So our psychiatry is online, our individual and family therapy online, including groups. We've kind of gone through different stages throughout this process as laws changed, more information that we learned. As we adapted, we learned, but we realized to help support our families and our clients, we really needed to make this shift pretty quickly. And so we've completely adapted, and now I don't see how we won't have this part of our program moving forward.
So you intend to keep doing telemedicine after the crisis is over?
In some capacity, yes. We're seeing a significant need. We're still having intakes pretty regularly. Families and individuals that are needing these services, that either they were beginning to work with an individual therapist and experience continued stress while they're at home under these circumstances and need really intensive treatment. And now we're able to expand throughout our whole state. So we're seeing this real need that we're filling right now.
Sherri, has your organization talked yet about whether you may continue after the crisis?
Yeah, we would definitely like to, and definitely keeping up to date with the different insurance companies, and going to follow and see what they're going to do and what their plans are going to be post, the submission of the bulletin for the 90-day waiver. We are hoping, we have found that there are a lot of, when you talk in therapy with your clients, there are barriers that sometimes stop them from getting to the office for services, right? And so now some of those barriers are just, they're gone. And some of those clients that struggled to get to the office to actually meet for session are meeting very regularly because of that barrier being gone. And now they're able to access our services more conveniently for them via the telehealth. So it's definitely interesting to see how the different individuals that we work with are liking it, not liking it, getting used to it. And some of them are even saying, I hope this just continues. This is really good for me. So we're definitely going to follow that and see what ends up happening. So.
I'm hearing similar things about some young people who are actually more difficult to engage in treatment in person. We're actually preferring telehealth as the modality. And certainly a number of parents, when you think about commute times, when I was seeing patients in downtown Boston, I had some families traveling from New Hampshire to see me, and it would be an hour commute each way, parking in downtown Boston for a 15-minute med check. It made absolutely no sense. And so I think that what we're going to find in a number of areas is that both some of the, particularly adolescents, but even some of the younger children, and certainly their parents, are going to actually prefer this modality over in-person visits. And I think it'll be very interesting to see, as some of the rules have been liberalized and some of the compensation and reimbursement rates have been equalized. So Blue Cross tended to pay less for telehealth than for in-person. And in Massachusetts, our governor has required all the commercial insurance carriers to cover telehealth at the same rate as in-person. I think that's going to be hard to reverse after the pandemic ends.
Yeah, so Michigan had telehealth reimbursement before the pandemic, and like you were saying, the residential program I oversaw implemented telepsychiatry, 7 years ago now. And at the time, they did it primarily because they were having difficulty identifying a psychiatry provider locally that met the needs of the youth. When you look at hospital systems as well, a lot of hospital systems were using telemedicine this way. So like if you were in relatively rural California and you had acute neurological problems, they would have a neurologist who is from a specialty center in San Jose or LA provide video teleconference healthcare because they couldn't have that kind of provider locally. But our youth as well had really positive experiences. And I don't know if it's because there's like a lag with the video and it's harder to, be reactive emotionally as a treatment provider as well in the video setting, or if it's less aversive to not be in the room directly with somebody if you're a traumatized youth. But when I was overseeing that, our youth had really positive experiences as well. The outpatient organization that I serve now is doing some care via telemedicine. Some of our care is complicated. And so one of the things I do is autism evaluations. And autism evaluations are an example of something that's really hard to do via telemedicine because they're very interactive. For young children, they rely on things like being able to very accurately determine eye contact. It involves playing directly with somebody, whether it's blowing bubbles for preschoolers or otherwise interacting in the moment. And those things are harder to do on video. we're looking at doing that in limited cases, but we've been avoiding doing those in person. Although some of our therapists, our ABA therapists, are actually doing work with families, like parent training over video teleconference. And then, so the second question is kind of a follow-up, but are there any special considerations that you have implemented as an organization with respect to telemedicine? And in particular, has it changed the way that you manage youth in crisis situations?
Yeah, the situation with crisis has come up a couple of times. And what we typically hear is individuals therapists who provide telehealth services are, upfront screening. Is this client appropriate for telehealth services? And then they're able to kind of determine what's appropriate face-to-face or telehealth. Right now, we just don't have that option. So we really need to, provide all of our clients with the best services that we can at this time, and it is via telehealth at this point in time. So we've gotten creative with ways to do we're also using the Zoom platform, the HIPAA compliant Zoom platform, for folks who can do the video. And so, making sure that folks are having copies of their safety plans at their fingertips. If we need to mail it to them, email it to them, text it to them, however that we can get it to them. There's also an app, a safety plan app that I've had a client utilize where they actually put their safety plan right into that app. So then they had it right at their fingertips. And then working with if you're working with the kids, you're working with the parents and making sure that they're also aware of the safety plan and what the coping skills are and why they're doing what they're doing. If they need some time away in their room, or if they're doing something in particular that's on that safety plan for a coping skill. So we need to be keeping the parents in the loop and involved. And we've had some really good success with getting some families involved and actually having even more family contact because we do a lot of school-based therapy sessions, and these might be families that we wouldn't necessarily have had as much contact with, but now we're providing the therapy and it's in their home. So we have gotten a little bit more communication with some of them, but just back to my point, making sure they're also aware of that safety plan and what's on that, and that folks have that. It's not just a document that I'm holding, but it's a document that is usable and workable and something that they have access to. So
what's that app called?
It's Safety Plan is what it's called, and it is through SAMHSA, I think, is who makes it. And it's a blue app with a white kind of cross thing on it, X or cross. But yeah, it's called Safety Plan.
So we can try to find we can get a link to the participants also. That's wonderful.
Yeah, it's excellent.
Yeah. So the way that we've been able to handle crises is, well, first understanding our limits as an organization within this platform. You're only able to handle kind of so much. We need a certain level of engagement. You need that in therapy to begin with, but you certainly need that in a virtual atmosphere as well. So first, just kind of understanding your limitations as an organization and what you're able and comfortable handling as well. So I totally agree. We've focused on increasing communication, just like Sherri said, with families. We've had more communication lately with our families than we had when we were in person, because we can't see them and kind of get that feel like we like to have as therapists and really get a sense for where things are. The screen can sometimes be a little bit of a barrier to that. Now, if you see them enough, you start to really understand it. Also, if you've had a prior relationship with them and you saw them in person, you kind of get to see the nuances of their behavior through the screen still. So obviously increasing that. And then obviously there's a significant amount of case management that we still are doing and have had to increase since we've gotten onto this platform. So whether it's communicating with the family, having more phone calls with or sessions with the individual. And since we run groups, we also use a HIPAA compliant Zoom platform, and there's a way for us to have breakout sessions. So if there's somebody who is in crisis that we identify in the middle of a group, co-facilitator is able to open up a breakout room and is able to go into the breakout room with that individual. Or if there's a couple of people there, just like you would normally do if you needed to pull somebody out of a group to address any sort of concern or safety risk. Now, this is really the time for us, as an outpatient provider, to utilize the different levels of care. So there have been times where we've had, just in the last number of weeks of us doing this, had to step somebody up to a higher level of care. Somebody had, even though you really don't want to go to the emergency department, but had to give the hospital a call ahead of time to inform them that we needed a psych eval done. So we've just worked really closely to ensure that if we don't have a good feel for it, we can get them to speak with somebody and get a psych eval done if they're significant suicidal ideation or increasing self-harming behaviors.
That coordination with local resources that are nearer to the patient or client is really critical. When I did care with the VA as well, one of the things that we did was we provided, at that time they provided care at these satellite clinics, but the individuals would actually go to a clinic, but it would be a clinic where there may not be people with our expertise, but there were providers there. And then having a relationship with an emergency department or other kind of local provider is very important.
Yeah, we've just in the last 2 weeks, sadly, we've had to send 2 separate clients to the hospital, but luckily we were able to work with them ahead of time, and they were able to get right into the inpatient unit that they needed to be in, and so we were able to case coordinate that, so there was no issue of any sort of contact. They were able to handle it pretty smoothly and ensure our client safety.
Just kind of connecting with that, I just want to throw in that we have been also as therapists asking at the beginning of session what the location is of our client, because if they're not in their physical home and they're maybe at a grandparent's or a friend's or somewhere else, and a crisis would come up and we would need to know their exact address location, if we would need to be sending any supports or anything there. We've been putting that in our notes and having a routine of just asking that at the beginning of every telehealth session.
Have you had any issues with youth not being, sorry?
I was just going to say, I think that's a really critical point to ask the young person who else is it in the physical proximity, because when you're in your office, there are certain assumptions you can make about privacy that you need to be more thoughtful about when you're doing telehealth. And it's a particular concern right now because the reports to child abuse hotlines and domestic violence hotlines are way down. And in part, that's because our contact with children has also been diminished as schools are closed and pediatricians aren't seeing children except for emergency situations. We want to be able to ensure that we're creating a space where if there is something untoward happening to the children, they're in a space that they can actually report that to us without the potential abuser overhearing, as well as just other even more benign aspects of our work. I think it works best when the people we're working with have an assumption of privacy, and I don't think telehealth, because you can't see beyond where the screen is showing, who else might be in proximity. So I just think that that's a really important point to highlight.
I was going to exactly the same place. As we think about youth who don't have a private room in their homes, there have been a lot of memes on social media about how sheltering in place can look very different for people in different economic or life situations. And you can't tell. Like, for instance, my husband is working from home, and since this is not a HIPAA conversation, he's actually right there. But you wouldn't know that because my screen doesn't show you that. And so, those kinds of issues are really significant considerations. When we talk about telemedicine, security and privacy, there's often a really heavy focus on digital information security, HIPAA compliant processes, end-to-end encryption, and those kinds of things. But we should think about these much more mundane privacy risks that can be really more meaningful, where the issue is not that a hacker on the internet is getting the information, but that your brother is listening in from the next room over or something like that.
Yeah, we've talked about offering, ourselves to wear headsets so the clients feel like it's comfortable for them to wear headsets. So then, obviously things are going to be picked up a little bit. They're going to still hear what the client's saying if a brother's in the room, but they're not going to hear what the therapist is saying back. So we've suggested that. We've also talked about the client and the therapist coming up with like a key phrase like, "Oh, how's the weather?" And that meaning like, "Woo, somebody walked in the room and I no longer feel comfortable talking about this topic anymore." So that's worked for some of our clients. And then also with those that are using Zoom, obviously some of you folks are using the chat box right now, just kind of popping on the chat box and saying, "Hey, so-and-so's in the room," and then that being their cue to each other. So really thinking through some of those privacy things, I really do think that is important.
That's a good segue to the next question I had, which is, are there any times you decide not to use telemedicine? Or are there times that you would recommend that other people don't use telemedicine?
So I think coming back to kind of the safety side, knowing when it's not going to be okay if somebody, for someone to participate, when they can't agree to the rules that we're talking about, that we've set pretty strong rules in the beginning, really recommending that we have headphones, are able to try to have some level of privacy if they're unable to get into just a room themselves, have a space where at least they can be kind of left alone. Be able to have the screen on. We've had that as a problem before, or they're not showing their face within the screen, because we really need to ensure that safety for our other clients too when we're talking about group therapy, that any other client's confidentiality isn't being broken. So one is certainly if they can't follow what those rules are, but also if it's too high of a safety risk, and sometimes, depending on the programs, we may see pretty high safety risks, and it may not be appropriate for them to participate virtually because we won't be able to get a good enough sense of where they are and be able to address their concerns that brought them into therapy in the first place. So we've definitely had to be really aware of who we can treat and what the struggles are. So really, again, understanding our kind of boundaries and limitations as an organization, and if we have a young person who's unable to do that, it would not be appropriate for them to participate because it could be harmful for themselves or others too.
Mm.
Yeah, I just echo what Nate said. It is all about safety and thinking about those clients whom we feel like are safety risks, and not being able to do that full face-to-face session with them. And going back to your last question about making sure that for those higher clients that are higher priority, that we're making sure we're doing everything, we're assessing, we use the Columbia for our suicide screener. So we're assessing for suicidality. It's spring, suicidality already spikes in the spring, and now we have COVID-19 on top of that. So we're really being diligent about, checking in with folks and assessing. And obviously you can only go off of what they're telling you in that moment, but you still want to be asking the questions. So.
Christopher?
I think the points that I would make have pretty much been covered. I think the young people, particularly the younger you go, I think it can be more challenging. And then I think the work is more dyadic. So you'd be working with the parent, caregiver, and the child. I think the young people can be much tougher. I'm seeing this also in remote education. How do you meaningfully create a preschool, kindergarten, or even first grade experience is much more challenging than trying to teach remote learning, social studies for a middle or high schooler. And parents with young children, some of whom might be our panelists nodding their heads, I think know how difficult that can be. And I think having reasonable expectations, one of the things that I just want, folks to take away from this session is, we didn't have a pandemic response plan, or at least most of us didn't. And I think a lot of us are kind of creating this on the fly. And so understanding that we're going to get some things wrong, which is why some of the rules have been relaxed. We're going to hopefully learn a whole lot and potentially take some of these crisis response strategies, and they may become part of our new way of working. And I think that's actually very exciting. And I was on a call earlier today where we were talking about the need to start gathering at least qualitative data, if not starting to gather some quantitative data about who are the young people that actually benefit most, whether by diagnosis or by age or developmental ability. Who are the families that like the technology the best? And what are best practices associated with telehealth? And there's a couple of resources I'll put in the chat box relevant to best practices.
Yeah, as a psychologist, I'll add as well that one of the more challenging areas is diagnostic assessment. Certainly, I think that you can do a basic diagnostic assessment as a psychiatrist, psychologist, or whatever, a social worker, or whatever your area of expertise is. But when we think about some of the testing, there are some really substantial questions that come up. And some of them are kind of surprising. Like there's been evidence that verbal tests, like verbal list learning tests or attention tests, where you would think that the platform would be relatively ideal for that because it doesn't involve any visual or physical interaction, that the results are actually substantially different when they're delivered over a telehealth kind of app than when they're delivered face-to-face. We've known for a long time that people perform differently as well on computer tests when examiners in the room with them than when they're not in the room with them. For some kinds of tests, like personality tests like the MMPI, there are test security issues as well. This certainly applies to things like IQ tests as well, where we do want to think to some extent about making sure that that information doesn't become part of public knowledge, because these tests are designed in such a way that they work when people don't know what's on them. So there are those kinds of limitations as well. Certainly with my autism evaluations, I really would not want to evaluate a 2-year-old for autism over the video because I think it would be really challenging. Just very simple things like eye contact. Like if I'm making eye contact with the person on the screen, then my eyes are not in the right place because I'm not looking at the camera, right? And so like those kinds of really subtle differences would be very difficult to gauge. And so that's one more consideration. But one of our participants asked a question, and I'd love to hear your thoughts, and I have a response to it as well. And the question that they asked was, in this kind of environment with all of these concerns, is it better to just not do telemedicine than to do a session with these kinds of limitations? And there, I think that for me personally, one of the big balancing act questions is, what is the impact of discontinuity of care? What's the impact of a person being out of services for, at this point, a somewhat unclear period of time, 4 weeks, 6 weeks, 8 weeks, maybe even longer than that? What is the consequence also if a person is seeking care? We know that people sometimes are primed for a variety of reasons to seek out care, and maybe in a place where they're open or capable of making a change in their lives at the time when they seek out care. And so from those kinds of standpoints, I've always felt that there is some value in providing care right in the moment. And sometimes these complications are manageable, and we should proceed. But I would love to hear your thoughts.
Yeah, I would say for us, we've talked about this a lot, and we've talked about how maybe the therapy for some situations, if the therapy that you were providing face-to-face in session is not something that you can currently do because of whatever constraints or barriers, maybe because of they don't have a quiet place, safe place to have a therapy session. Let's just use that as an example. Then we think about other ways that's still things that they're agreeing and wanting to work on, so we can still be engaged with them, but maybe things are going to look a little bit different. So for some of our therapists, that's looked like a little bit more family contact, because the family is right there. So maybe that wasn't necessarily a part of the original treatment plan, but now we can go back and we can make adjustments, and that can be a part of it, because that's all still good work to be done. In other situations, if someone's not feeling really safe to talk about certain things, then we've talked about different ways that we could provide them some resources that, we can still have sessions and we can still work on things and talk about things, but as things come up, if there's anything we can connect them with, maybe a specific article to read or an app to use or something like that, that then we can kind of review those things. So that's just a couple of thoughts that I have and experiences that we've dealt with. So sometimes the treatment just looks a little bit different right now, and that's not a horrible thing. It's just different, and the relationship is still, the therapeutic relationships still being there is really important.
Yeah, I totally agree. I think first is just kind of assessing what is the safety risk that we're having here. Is this that they're struggling with maybe the one particular part of treatment? Are they struggling in individual sessions or group? And I believe it's our duty as a therapist to be able to then adapt and be able to help provide those services to them once we've truly addressed what that safety concern is. Now, if it's somebody that's in the home and we're concerned, then we need to kind of find a way to maybe have a conversation with them. And if they need to report something and they say, they're not feeling comfortable at home because of abuse that's there, then that way we can get that information and report it so that the proper channels are brought in. I do believe it's just a lot of it is adapting our treatment, and so we've had to do this before where someone has really struggled in the group setting. We do this often in person as well, and then we've kind of slowed down treatment for them. So what that means is, we're going to take you out of the group for a little bit, and we're going to work more individually and a little bit more within your family, and assess and see what the best way to move forward is. So we've had to do that actually just recently, and somebody's just re-engaged at the end of last week after kind of taking a week off of group because they're really struggling with the adaptation and joining a new group in this new setting. So just really kind of working with where they are and making some changes on our end. This is all brand new for most of us. And it's newer for our clients too. I actually think that they're a little bit more used to this than us. I actually think that we have this is new for us as therapists. And so it's just harder for us to actually adapt than our clients.
And it brings up kind of this almost like a countertransference issue that we need to be aware of our biases. And, it may be that we are technologically averse or change resistant. And so we're imposing some of that on our patients or clients, and they may not feel that way. But it also brings up another thing, which I wanted to ask about, which is, as I've worked with people who do telemedicine or teletherapy, every once in a while, the issue comes up that the establishing ground rules of understanding, the fact that this is an e-interaction, but it follows the rules that apply to the kinds of services we provide, and not the rules that apply to, Facebook or message boards or those kinds of things. As an example, youth may be used to being on social media where they have a certain degree of anonymity, or they may feel like certain barriers are different over a computer. And, we know a lot of people who say things differently online than they say them in person. So I'm curious about whether you do anything special in the process of introducing a youth or a family member to a video therapy relationship with the first time that you have a session like that.
We try to let them know that it's, logging on to Zoom or, calling in if they're doing a phone call session, that, consider that to be your time and space where you're having your therapy session, just as if you were in the office. So, the jokes that go around about somebody taking their therapist to the bathroom with them, I've heard that from my therapist. So you do have to set these ground rules. Taking your therapist with you to the bathroom via Zoom is not okay. So setting those ground rules of it's, the same thing, if you do need to use the restroom, just let me know you need to take a break. And kind of going over all of those pieces, finding a private place, that you can, as private as you can to be in, and making sure that everybody's present. We've had that issue with some of our psychiatric appointments where mom was in one place, the kid was at, if the parents were divorced, the kid was at the dad's house, but we were told to do the Zoom with the mom, and then the kid's not there, and we're like, well, we need the kid to do the appointment. So we've been really trying to clarify who all is going to be a part of this next appointment, and that they all need to be, if we need to send multiple Zoom links to multiple locations, that's okay. Whatever works. But we need to make sure that everybody is available. It's not just a phone call check-in, like a contact. This is actually your session time. So
something that we've done is when we first made the switch into 100% virtual, we let the families know that we would be in contact with them pretty regularly. So we would constantly be sending them more and more information about it. But each family that's engaged or individual that's engaged in this has all gotten their own separate forms to kind of outline the rules. But also, I think repetition is the most important thing. So repeating it really regularly for everybody at the beginning of individual sessions and family sessions and groups, just really reviewing what the ground rules are and the program boundaries. And again, it just kind of comes back to safety and also effectiveness within treatment. If we don't establish those boundaries, then we are going to get a tour of the kid's house, which is fun, and we can do that, and that can be an activity, but it can also be distracting too for what we're trying to get done in the session. So I think just being really, aware of, they may have, look, we're all going through this together. So when they heard it the first time, maybe they didn't totally hear it, and we got to be patient with one another and just keep repeating it in different ways, just to ensure that they understand kind of what the boundaries are in this format.
Yeah, I think that those are great points. it's good to set the boundaries up. And then also, I think kind of goes back to something Sherri was saying, which is that we should all be mindful that this is a really unique circumstance. I remind people that the last time this happened in the United States was about 100 years ago. And so pretty much none of us were around at the time. And so we're all doing this for the first time. Even thinking about stability goals can be really important for individuals at this kind of critical time where, maybe we need to not push people too hard. Just like the conversation has been going on with education about how maybe we shouldn't be killing ourselves to try to meet specific quantitative goals in education right this instant when youth are dealing with so many other challenges. I would love to move on to asking you all next about any other tips or tricks you've learned along the way. One that I'll throw in there is that, we may have touched on this indirectly, but if you already have a face-to-face relationship with somebody, I wouldn't underweight the fact that that is a different scenario than meeting them on the video for the very first time. Because that rapport that you've built in person I really do think it carries over to your interaction with a person in any other kind of medium, whether that's phoning or emailing or texting or video conferencing with them. So I would think about that as you think about your best candidates for this. Tips or tricks?
So I can start, I'll start pretty basic. So I think it's just preparing your staff and your clients for any technical mishaps. I think it's a great way to kind of help position you as well if you're someone who's thinking about implementing this as kind of an expert. So just simple ones are clearing out, closing out other pages, making sure your Wi-Fi is strong, ensuring you've got headphones on, because strangely enough, that actually helps the connection in some capacity. Mm-hmm. And being able to just roll with it when something bad happens. So, hey, if we lose connection, we'll figure it out, and let's log off and have each other's phone, have your client's phone number too, just to be able to coordinate in different ways. But I think the biggest thing is really finding ways to ensure that the video isn't a barrier. Still be engaging in your sessions. If you're somebody in our program we do this all the time. We do experiential activities quite frequently in person, where we'll take kids on hikes and we'll do experientials in the moment, and we do art therapy. So that's been the biggest adjustment for us. And we've just pushed our staff to continue to be engaging and be creative in this way. So we'll do mindfulness. I participated in a mindfulness dancing activity that went on for about 30 minutes, but got the kids up and moving around. Last week, I ran a multifamily group where we all worked together and created genograms, but I prepped them before to have paper and pen and ready to go. And it wasn't perfect. Normally, if we were in person, we'd be drawing it on our board, but they showed it to the camera. So I think just really finding new ways to be creative and be engaging throughout this. Yes, the screen is a barrier, but it doesn't have to be. And there are definitely ways to work around it. Using multimedia, there are virtual tours you can go on if you're working with a group and you like to do kind of some of those different things. So, I would just recommend, not being too hung up on this new platform and find new ways to do the great work that you do.
Yeah, I agree. Something that we want our therapists to be who they are, and I want to be who I am whenever I'm doing therapy sessions. So I don't want myself to change because of the screen either. And I don't want my therapist to change or my psychiatrist. So we still want to be us. We still want our personality to shine through, because that's all part of the connection between the therapist and the client. The other thing is just kind of building some competence in the therapists who, this is all like Nate said, this is all new for all of us. And I can't claim to walk in the door and be supervising folks and say, I know how to do this. Let me help you learn. Because we're all learning together. But what we've done and what I've done is I've created opportunities for folks to jump on a meeting for therapists from all over, community-based, partial, any family-based, and any teams across Presley, and they've been joining and sharing things that have gone good, things that they're struggling with. Other people might have answers, things that they've tried. So this has really been a nice way to help colleagues kind of work together and to help them feel a little bit more competent on their skill basis on doing therapy virtually, right? Because we have a lot of competent therapists that are really solid with their skills when they're sitting face to face, but all of a sudden we threw this loop in where they're now doing it virtually, and so it's a whole new thing for them. So those are some things that I thought of, and then Nate's right. I mean, we're just trying to really, especially with the kids, trying to be creative and engaging them. You know, for the most part, the adults and some of the teenagers are fine with more of a talk session, and they're fine with that. But the kids and family sessions and groups, we got to get ways to engage them. So, you know, we've done some virtual scavenger hunts. We've had families create some, you know, prepare some things that the kid has, maybe some Play-Doh or a rice tray that they can have. We've used, since we are using Zoom, there's the whiteboard that you can use to be able to color and share that together. We've been reading stories together with them. So just finding all kinds of different, interesting, creative ways that we can engage. And even some of our older clients that liked to maybe listen to music or share some music, then we've been able to utilize the technology. You're already on your computer. Let's hop on YouTube and search up that song, and maybe we can talk about that song and what the meaning is for them. Also on YouTube, there's lots of different mindfulness activities and exercises on there that you can log on, and you could do right there with your client and practice them. And then they have it at their fingertips because they know where it's easily accessible, so they can go on and find those. So it takes our brain, and we got to think outside of the box for our creativity, because maybe not what we used to do is exactly what we used to do, but we can still find a way to do that and be us, even though we're virtual. So I think that's all a learning experience as we're working through this over the last couple of weeks. So
that's a thing to remember too. When you say last couple of weeks, many of our organizations have made changes over very short periods of time.
Yeah.
We get some great comments about that as well. Playing guitar, using Legos for the zones of regulation. As I was listening to you and Nate, Sherri, one of the things that made me think about was that, in a way, I mean, we always talk about, as ACRC, we talk about being aware of the strengths. Residential care, for instance, is something that a lot of people would rather not do if they weren't in that situation, but they are. And so we look at the opportunity to turn that into something positive for people. One of the positives of doing this therapy with people in home, certainly is that when it comes to giving people homework and then having to figure out and problem solve, not in real time, for why they have trouble doing those things in their homes, in a way, it's a strength to be doing teletherapy because you can figure those things out, and if they can figure out right there with you what they have access to and what they don't have access to. So the homework you give them or the activities you come up with, that they can do them.
Mira, that's a great point. I totally agree with you. I started my career off in a lot of training, doing a lot of in-home therapy, where you were able to really see what was happening within the home. I liken this experience virtual to that, because we really get to see what resources they have at home, Practically speaking, we can come up with a great intervention in the clinic, let's say, but maybe they don't have that at home, but we're able to get great information and find out, actually they've got these other resources and they have these new interests. We had somebody just the other day who had a really tough time opening up in group, and then he showed the group his ukulele, and then they were talking about that. He was talking about that for 15 minutes and didn't talk for nearly a week in the group. So I think we're just getting a lot of really amazing engagement in a new way that we weren't really expecting. I agree. I think the recommendations in the chat box, I agree. I love that people are thinking like this. We can act very experientially in the moment, just with what's present in the home.
It's like a whole new level of the other 23 hours.
Oh yeah, yeah, definitely.
I really appreciate that you don't emphasize that the technology is the primary thing to get obsessed about, because I think it's really easy to do that. I think that those are great tech recommendations. Like, I'm wearing earbuds right now, and I definitely recommend those, or headsets, just practicing normalizing those kinds of things with patients or clients or families as well. But by and large, this is more about how to get used to the experience. I'll add in that just doing video teleconferencing, like jumping on Zoom like this, is helpful. The more you do it, the more comfortable you are with this kind of situation. And that's true for anything. I mean, we're therapists and mental health workers. We know that. But to, share my own personal experiences, I ran an engineering project when I used to be an engineer with an engineer from Mexico for months. And I was working with him for like a year before I met him. But after a while, I got used to making phone calls to Mexico and knowing how to navigate the cultural barriers with somebody I'd never met in person before. And we can adapt to all of those kinds of things. Once you get used to using these technologies too, there are things that don't work as well. Besides eye contact, reading very deeply into facial expressions is harder because it depends on the bandwidth and the camera quality and all of these other factors that you may not control. There may be distractions that are unique to the fact that somebody's at home, because even if they have their door closed and they're in their own room, their dog starts barking or their cat starts meowing. And those kinds of things can be really helpful as well. To be aware of them, to not overweight things that maybe are not as applicable in the digital interaction. But to also get the practice with them so that you're comfortable with responding in real time and understanding how somebody's doing on video instead of having them in your office with you.
Yeah, you brought up the point of the facial expression and eye contact, and we talked about this in the group that I'm leading with all the therapists, and we had some really good discussion because I think that's something we really need to think about in many different ways, because the way we are sitting here and we can see each other, we're actually sitting closer in some ways to each other's faces than we normally do with our clients in an office setting. So if you do have a clear video, you might be seeing more about their face than you would in an actual face-to-face session. You're missing the rest of the body, right? That they're moving their legs or tapping or whatnot. And then, so we talked a lot about that. And then we talked about, clients who maybe are only showing like a portion of their face, and what is that about? Is there some sort of piece of them that's feeling a little bit weird about being on the camera? So how to kind of navigate and work through that all therapeutically, and not just assuming it's a teenager being a teenager. There might be something a little bit more to that as to why they're not wanting to show you anything but their forehead or their eyes or something like that. So, and then we also had the flip conversation that if that's where the client is comfortable for X, Y, and Z reasons, then as a therapist, are we comfortable with working with them at that point, where if they're only feeling comfortable to show their eyes and their forehead, and you as a therapist, are you comfortable with that and able to help kind of work to the point where they're able to work with them and provide the therapy to get them to where they're feeling a little bit more confident to be able to show their whole face on the screen. So interesting pieces and lots of good conversations. So I definitely think that's a worthwhile exploration for all therapists to be thinking about facial expressions and eye contact.
Yeah, as a therapist, again, this is a tech tip and trick, but one thing to think about is sometimes, like, if you want to give really good eye contact on a video conference, is a reminder to look at the camera and not to look at the screen, especially if those are not that close to each other, or if you're very close to the screen. So the closer you get, the bigger there is a difference between whether you're looking at the camera or looking at the screen, like if you're looking at the person on the screen. And so think about those kinds of things as well. Although I think you want to not get yourself so caught up into trying to manage that you're not doing your job as a therapist. Mm-hmm. And I love what you said too, that, you can turn all of these things into useful information. If a youth is communicating with you in a funny way, like, being half off the screen, then what does that tell you? Once you figured out that it's not because they need to adjust their whatever it is, or chair or whatever, what does that tell you about where the youth is at, and why they're having that experience? And maybe you actually learned something that you wouldn't have learned in an office where, they can't do that to you. What I'd like to ask next is, if an organization is thinking about making a change in implementing telemedicine, what are some next steps to be thinking about? We talked about the HIPAA compliance and understanding all the technology, and we're going to share some resources. I've got a link that we're going to share from APA about that. But what should you think about next?
Yeah, so I think outside of just kind of really understanding what your local, your state laws are, what you're able to do, and ensuring kind of funding and what does that look like so you can project that out, and having the platform available. I think just kind of starting to create kind of what your rules look like for your organization to go virtual. Again, so just like what we've been talking about before, is just having those boundaries, kind of ground rules. What are you okay with? What are your limitations as you're entering this platform? Understanding that, and then really, it's just get started. Really get started, and know that what you put together at first is not going to be perfect. You, just like we are all learning. We're all learning from this experience, and it's constantly evolving. So as you've brought your practice online, you're going to start figuring out what works for you and what doesn't work for you. But as long as you've covered your bases, and you've got all those pieces, they all check off, coming from the legal side and funding, and ensuring you've got the appropriate platform, and just create kind of a rough sketch of how's your program, or maybe if you're an individual practitioner, how does your practice function regularly, and then just get rolling with it. Because I think it's a lot of our worries. It's ours. We're used to therapy happening in person, and for most of us, this is brand new. Well, actually, telemedicine and teletherapy has been around for some time now. This has been the one event that's shifted us all into, or really thinking about teletherapy. And I really truly believe that this is something that is going to stick around. It's not going to be the only thing, but I do think in each practice or program or organization, it will be present in some capacity, because we're starting to really see the real benefits from it. So I really just recommend, and we're like, Mira, you said, we're all therapists, we all get it, and how to make a change. And really, it's just kind of jumping in and getting started and learning from it.
Yeah, I like what you're saying. We will share the APA guidelines on teletherapy. And when I pulled those up today, I was like, my gosh, they're from 2013. And I actually did some telemedicine work in the previous decade as well. So even, significantly before that. On the positive side, the technology is much more accessible today, just in the sense that, as opposed to 10 years ago, now everybody has devices with cameras. It's much more likely that your youth have access to a tablet or a laptop computer with a camera. And those things are very helpful. But the idea is not new. And I agree. I think that we will see more of this in the future as a result of this.
Yeah, the only thing I would really add to that is, just as we're kind of thinking through, is thinking about some just like general assessment questions that we would ask clients initially up front to help determine rather, face-to-face or telehealth is a better fit. And some of that could just be literally about barriers to getting to an office. And some of them can be more technical about treatment and treatment modalities and things like that. So I don't necessarily have those questions formalized yet, but that is something that I'm working on creating. What is it? What are those questions that we want to be asking so that we're finding the best fit for this client?
I mean, I do think that we want to ensure, once we've caught our breath, that we are integrating policies and procedures, adapting consent forms, being clear with the clients, as we've talked about expectations on their part in terms of participation. And we can have those for the young people we're working with as well as their caregivers. So we operationalize and put some guardrails around what this practice should look like. And, I've already shared, there's the American Telemedicine Association guidelines specific to children and adolescents. So that's in the chat box. The American Academy of Child and Adolescent Psychiatry has a clinical update on telehealth. So a lot of people have been doing this for longer than all of us, have provided us with some really nice best practices and best principles. Then I would say we also need to do some advocacy about ensuring that the reimbursement rates continue to be on par with in-person visits. And that might mean partnering with the consumer groups who I think are going to be pretty vocal about insisting that this new way of doing behavioral health doesn't go away after the pandemic. And I think the pandemic, for better or worse, will probably provide that ongoing opportunity for us as we have continuing hotspots popping up and needing to re-engage social distancing periodically until we have a vaccine or an effective treatment. So, I love all the comments about, kind of jump in. In medicine, we have a commonly used phrase, see one, do one, teach one. And so I think for telehealth, have somebody mentor you, show you how to do it, try it, and before you know it, you'll be teaching others how to do it. And like I said earlier, I think there's a lot of young people who are actually going to prefer this approach to going back to in-person treatment. And I think that's really exciting, and, in crises, there are opportunities. And I think the more adaptive you can be in your practice, either as a clinician or as an administrator adapting the practice to telehealth, given the vicissitudes of our response to the pandemic, I think the more likely you're going to be able to survive this pandemic as a treater or as an organization.
Yeah, for those attending, this is a reminder or prompt. If you have questions, we would very much welcome them. But and Bob Lieberman wrote in a comment that Youth ERA is doing some really great stuff virtually, and we're going to share a whole bunch of information with you. I'm not exactly sure how we're going to do that, but Amanda is going to make information available. We'll either email things to you or make them available via the ACRC website. But we have a bunch of resources. Chris has shared some great things. I've got a couple of documents that you can look at, and we're happy to bring all of this material together for you. And I think that certainly Chris's comment about see one, do one, teach one is apropos to us. As some of you may not have foreseen yourself being on a panel talking about doing telemedicine prior to when we asked you to do this just a few days ago. So I certainly appreciate your willingness to be part of this. My experiences have been really positive with it. And so I encourage people to take the steps, but jump in. Going back to something else, I think maybe Sherri or Nate said, if you are part of a system of care, if you are in a community mental health system or another kind of statewide system, definitely reach out to that system, because you are not the only one asking these questions. That's why we put together today's webinar. But more generally, you'll find out that other people are working on these things locally as well. I reached out to ask questions about what was going on in autism, and it happened that our state was doing a webinar, which was just a couple days ago, and I found out about it because I reached out and asked people, and I was able to connect and hear from practitioners in my expertise area as a part of that. That's also going to be really helpful for navigating the specific issues that have to do with your funding sources and your local laws or regulations. So definitely reach out to any system that you're a part of to get that assistance. All right, well, I would love to open it up for any other comments, and we have a few minutes, see if anybody asks any questions. Anybody have anything on their mind that they haven't had a chance to say yet?
You know, I think the biggest takeaway from me in this experience, like I said before, we have a clinic that we've really been focused in just, in-person work. I never really thought that we would be making any sort of leap into teletherapy. And just as Chris had stated, within crises, there are opportunities. And, I'll just say from our experience, obviously there are bumps along the way in kind of adapting, and we've kind of moved along and tried to figure out what we could do best. But really, I see this as a really nice opportunity for us in behavioral health care in moving forward. Especially with our youth, I think that, Gen Zs and millennials too grew up with technology, are far more comfortable with that. We all have computers in our pockets that have front-facing cameras. So I think really the best thing that we can do in behavioral health care is begin to provide more access. And I think that this is a new way for us to provide access to more people who need this care, especially across a state. So I'm in the state of Maryland, and our clinic is right near Washington, D.C. But this opens an opportunity for us to now treat young people in parts of Maryland that don't have access to our treatment. So more people are able to have access through virtual programming or telemedicine. So it's something that I'm just really excited about. I never really thought that I would get into it. I remember attending a conference a couple of years ago where they talked about it, and I was really worried, and I thought, there's no way I'd get into it. And this crisis was something that just kind of pushed me and totally changed my view on it, and also our full organization. So, I have other colleagues that are in private practice who've made a full shift, and they're seeing the benefits of it as well. Being able to continue to provide care for their current patients, but also bringing more people in and being able to assist more people. So I'm just really excited about this topic. I really appreciate being included in this panel and being able to talk on this.
Yeah, I think so. When we were chatting before we went live, you had mentioned some of the wrinkles with the fact that you live in an area where you're very close to multiple states,
Yeah.
and licensure kinds of issues.
Sure. Yeah, I can talk on that. So where we are, we have clients or young people who are in DC, Maryland, and Virginia. So our office is just across the Potomac River, and on the other side is Virginia, and then 4 miles down is the border of DC. So we've had to really work with the insurance companies to see what coverage would look like. We've had to adapt a few things. And actually, we had a huge victory recently where we have a young person who lives in Virginia, and Virginia and the insurance company agreed to cover not just outpatient level of care, but our facility billing and intensive outpatient program, which is a huge victory for us. So we're starting to see that the insurance companies are starting to, do what makes sense, and that's really what it is provide the care that's needed. So most of our clinicians are only licensed in the state of Maryland. So we're also looking into ways of seeing how we can expedite licensures, getting licenses in Virginia and Washington, D.C. So it's interesting. The legislation allowed for us to practice in other states, but it didn't necessarily say that we would be reimbursed. So hopefully there's legislation that really across the country that allows for that to happen, especially during this crisis. But see what happens from this point on.
That goes back to Chris's point about advocating for reimbursement practices. Really, this comes down, I think, after the crisis. During the crisis, this comes down to a way to safely provide critical services. After the crisis, this comes down to providing services in a flexible way that meets the needs of patients or clients who may prefer the flexibility, who may want a mixture of in-person and telemedical services from you, and who may be used to using their technology for everything else. Like if I can use my phone to get food delivered, and I can use my phone to order services on Amazon, and I can use my phone to control my car, why can't I use my phone to get medical care? And so advocating for reimbursement, advocating for patient and consumer-friendly practices. Sometimes that's also educating the reimbursers about the costs and things. And so doing telemedicine is not free. It doesn't somehow magically reduce costs. Most of you will continue to have offices in the future, and so those costs don't go away. You may also have new costs that are associated with the technology, like paying for HIPAA compliant services like Zoom with HIPAA. And so providers need to be aware of those things and reimburse appropriately. Let's see if there are any questions in here. I don't see any others. Any other closing thoughts? Chris or Sherri?
No, I guess the only thing that I would say is just, as we're going through this pandemic and we're utilizing the telehealth services, we need to continuously think outside of the box and be creative. So that can never stop right now because this is just all new. So for what we're doing, so creativity and thinking outside of the box is what I just keep preaching to myself and my team. So.
One of our. Go ahead, please.
Go ahead.
Oh, I was just going to say one of our participants commented that some states have registries of providers who provide telehealth. Oftentimes those registries are also available via professional organizations. And so, Psychology Today or Therapist Finder kinds of websites, or the NSW website as well. But if you are able to join one of those registries, then consider doing that.
Another registry that I've heard of is onlinecounseling.com, which I think there's a way for you to get that for free if you put a link basically onto your website. So you'd have to work with your administrators too. But if you're an organization, this is something that I'm looking into right now, just to be able to be listed as someone who is an online provider, and it would be totally free. If you don't put the link, I think there is a kind of small fee to be listed, but it's just like Psychology Today, but it's just for people who are providing teletherapy.
There are some platforms as well. If you become a teletherapy nerd and decide you fall in love with it, there are actually platforms as well that allow you to provide services and handle a lot of the back end and those kinds of things. Mm-hmm. And so, yeah, that's a great point. As the technology evolves, then people may use different kinds of resources to connect with providers, and we should adapt to that as well. What is that online therapy called again?
Onlinecounseling.com.
Okay, thank you.
Yep.
And I would just chime in that while we've been mainly focused about delivering therapeutic services through telehealth, there are lots of other useful applications, including particularly in the residential space, facilitating visits, because I would assume that a lot of residential providers are not allowing family visits. So it's a way to use the platform to keep young people engaged with their parents, their caregivers, their foster parents, even their friends, again, in a monitored way. It also is an opportunity to keep our staffs engaged with each other and with us. And I think there was some brief discussion about remote supervision and other ways that this could support the work as we're all trying to adapt to working from our homes. We didn't really get into the challenges of our own families and creating that safe space for us to have these conversations, and the challenges. I know some of our staff who are living in small urban apartments, studio apartments, are doing their telehealth in the car because they have to take turns sharing the physical space with their significant others who may also be telecommuting. And so I think people are coming up with adaptive ways to figure out how to make this work. And I think one of the messages is we're all figuring this out together. And so there's an opportunity there to begin to gather best practices, shared lessons, in order to better our practices as we adapt to this crisis.
I really appreciate that as we think about where a lot of people working from home, even outside of telehealth. It can break down the barrier between work and the other aspects of your life. And as therapists, be aware of the things that you need to do for your own mental health and well-being. With that, I want to thank you all so much. Thank you to Sherri, Nate, and Christopher, our wonderful panelists. Thank you to ACRC for putting this together for us. And thank you all of this for being, as Chris just put it, our Zoom happy hour. We're so happy to be with you today. We're going to get you a lot of information offline after the fact. We're going to put together the links that are in the chat as well. We'll figure out how to do all of that and get that out to you all. Thanks so much, and have a wonderful Monday, everybody.